Urology, presented by Dr. Scott Egner, Associate Professor of Surgery, Section of Urology at University of Chicago. Please give a warm welcome to Dr. Egner.
Hello. So I am here and designated to give you your dose of urology for the day. And I've been giving this talk for years for the initial boards and for the MOC. I try to pack in as much stuff as possible. It's going to be a bit of a whirlwind tour, so we'll go pretty rapidly. And I would like to leave a chunk of time at the end for the questions. That's certainly a valuable time. I would ask you quite frankly, if you can give me feedback. I incorporate feedback all the time into my talks for the following year. I am very good at accepting criticism. Tell me what needs to be cut, what was useful, what needs to be expanded, and I will listen. And lastly, I would tell you, you can email me anytime if questions come up. Usually every year I get a couple emails as your test is coming up, and I'm happy to help in any way. All right, let's dive in. I have no financial skin in this game with anything that I mention. So this is what I want to go over. Basic anatomy. So question, a 53-year-old male presents with a recent history of right scrotal swelling and pain. On examination, he has a large unilateral right varicocele, and his urinalysis is normal. The most appropriate next step is A, urine culture, B, urine cytology, C, CT scan, D, varicocelectomy, and E, orchiectomy. Good, C. That's the highest ever, I think. That number of you got it right. We got a smart crew. I usually put this one first because it validates my reason for being here. A lot of people get it wrong. So varicoceles are very common on the left side, very rare on the right side. If you have a unilateral right, you want to take a picture up top and just make sure there's nothing blocking the right gonadal vein. Renal anatomy. So the kidney is invested by some fat and then Gerota's fascia outside it. Most people don't realize that it's a closed space except for on the inferior side. So if someone has a stone obstructing them and urine leaks out, you'll usually see it go inferiorly and track along the psoas muscle. The renal hilum is notorious for having accessory vessels and variations, up to 40% of people, but the standard and the most common is the renal vein is most anterior, then the renal artery, then the UPJ, which is the ureteropelvic junction, or the collecting system for the urine. Gonadal vein, we alluded to earlier. Left side almost always goes into the left renal vein at a 90-degree angle or somewhat close, which is why it's far more common to have varicoceles on the left side. But on the right side, the gonadal vein most commonly goes directly into the vena cava at a different, less of an angle. So the flow is usually a little bit better. Renal venous anatomy. This is relevant and might be useful once or twice in your career, depending on what your practice is. The left renal vein has a lot of things dumping into it. The lumbar vein, gonadal vein, and then adrenal vein. There's practical purpose to this in that if you're doing a surgery up near the left renal vein and get into trouble and bad bleeding, you can tie off the left renal vein medial to all those vessels, and that kidney will still live. And I've used that before. On the right side, you don't have that luxury. So the right renal vein typically does not have a lot of collaterals going into it. And if you tie off the right renal vein, there's a pretty good chance that that right kidney is dying, or will pump up with blood first before it dies. So ureteral anatomy. The ureteral anatomy is relevant more for us than you because stones get caught in preferential areas. The three narrowest areas to the ureter are the UPJ, which is up by the kidney, when it crosses the iliac vessels, and then the UVJ, which is probably the narrowest area as the ureter goes into the bladder, the ureterovesical junction. It is relevant for the blood supply. So particularly in someone who has compromised blood supply, peripheral vascular disease, radiation, if you're trying to protect the ureter, you want to pay attention. Up top, sort of your upper and mid ureter, the blood supply comes from medially, from the aorta, from the renal artery, from lumbars, whereas lower down, it comes from lateral, so it comes off the iliacs typically. And so if you're trying to protect blood supply, that's relevant as you're mobilizing things. The ureter, for most part, is pretty forgiving, particularly in a young, healthy person, and you can get away with things without worrying about stricture down the road. Bladder anatomy, there's some embryologic stuff that I've listed there. If you're looking down into someone's pelvis and you see the bladder up against the anterior abdominal wall, the midline is obviously the urachus. There's sometimes tumors that can develop there. That's the median umbilical ligament remnant. Just lateral to that are the obliterated umbilical remnants, which are the medial umbilical ligaments, and then the lateral umbilical ligaments are the inferior epigastrics. Probably the single most forgiving urologic organ from a blood supply is the bladder. So you can do a lot with mobilizing the bladder, and you don't have to worry about it. And this is relevant if you have to lift the bladder up to reach a ureter, and we'll get to that later. All the blood supply comes off the hypogastric. There are some named vessels, the superior and inferior vesicle. You can usually only see the superior vesicle. All the others are just a network of blood vessels feeding into the bladder. The trigone has a different embryology, and it's at the base of the bladder. It's triangular, and it's bordered by the bladder neck, which is where it meets the urethra, and then the two ureteral orifices, which, as you know, is where the ureters dump into the bladder. Genital anatomy. So just to get sort of the forward flow of how sperm goes. Sperm goes from the testicle through the epididymis, from the head of the epididymis to the tail of the epididymis, then up the vas deferens, and then usually goes up by the prostate. From the prostate, it goes into the urethra where it meets fluid that comes from the seminal vesicles also into the urethra. Most people don't realize that the bulk of the volume of the ejaculate comes from the seminal vesicles. Actually, about only 10-15% comes from the sperm itself. The processus vaginalis you're familiar with. It's in the inguinal region where you're doing hernia surgeries. We're doing some hydrocele surgeries or orchiectomies. There can be a communicating hydrocele, usually in kids, if that processus vaginalis is patent, which is why many kids get hernia and hydrocele repairs at the same time. However, adults typically have non-communicating hydrocele. So if we see someone with a hydrocele, we're rarely, if ever, worried that it's somehow communicating back up into the peritoneum through a patent processus. We have different anatomic regions of the urethra, and you can go from the anterior urethra in the male, and that goes into the pendulous urethra, which is basically all the urethra that can sort of hang and swing. And then as you get in sort of the urethra that enters the body, it's the bulbar urethra. And then the bulbar urethra connects to the prostatic urethra, and then ultimately up into the bladder. Penile anatomy. This is a cross-section of the penis. It's a little bit different when talking direction. So the side opposite the urethra is the dorsal side. I always think of it, and I know it sounds a little bit crude, but you think of it as a man laying on his back with his penis up on his lower abdomen, thinking dorsal ventral. This is a cross-section. The middle has, sort of the cavernosal arteries go through the erectile tissues. The erectile tissues are basically what fill with blood. And so those react and dilate, blood fills in, and then there's the encasing on the outside, which is the tunica albuginea. So the blood fills in, but the tunica albuginea is sort of like the lining of a sausage where it fills it in and it can't expand any further, and that's how a man gets rigid. The urethra is obviously on the ventral side. That is covered by the corpus spongiosum. And then there's all other sorts of fascial layers that probably are not relevant for you, and I'd be shocked if they ever tested you on it. Trauma. Nowadays, many of you in the room probably know more about urologic trauma than we do because so much of it is non-operative and we rarely get called for it. Let's go through a couple perhaps challenging cases. We will find out with your responses. A 26-year-old female presents following a high-speed motor vehicle accident. Gross hematuria prompted a CT scan, which was normal, and then a cystogram revealed an extraperitoneal leakage of contrast from the trigone of her bladder that communicates to the vagina. Vitals are normal, there's no other injuries. What do you do next? Oops, sorry. So Foley catheter drainage for at least 10 days is the most common answer, and it's incorrect. That would be great for a standard extraperitoneal injury. However, when it communicates to another organ, there's certainly high risk of fistulizing, so that would be a situation to consider an exploration. It's not urgent or emergent, but at some point to fix it prior to it fistulizing. Next is a 34-year-old male who presents with a popping sound during vaginal intercourse and immediate loss of his erections. Physical examination shows an ecchymotic and edematous penile shaft. He is urinating normally without hematuria. The most appropriate next step is cystoscopy followed by penile fracture repair. B is cystoscopy, C is immediate penile fracture repair, D is observation, and E is a CT scan. It says polling's closed. I screwed this one up because I clicked ahead too fast. The bottom line is, and the point I want to get across is, with penile fractures, about 10 to 15% of the men also have a concomitant urethral injury, so you need to do something to evaluate that. It's usually a retrograde urethrogram, or if you have a urologist nearby, they stick a scope in, usually in the operating room, just so that you can find it out if needed. Good. 2 of the 3 people got it right. So, indications for renal imaging. So, penetrating trauma with any hematuria, microscopic or gross, and then obviously using, the art of your clinical suspicion. Blunt trauma is a little different, in a completely different category, and these are adults that we're talking about. Blunt trauma with gross hematuria is an indication, but blunt trauma with microscopic hematuria is relatively rare and no need to go imaging, and there's pretty good data on that. So microhematuria with shock and vascular compromise is certainly worth imaging. It would be impossible that they get shock from the microhematuria, but it's certainly, the shock is associated with more serious injuries elsewhere. So again, if you're suspicious with blunt trauma, you image, but other than that, you can preclude a diagnosis as long as they don't have shock with their microhematuria. Pediatric trauma, I honestly don't see a lot of it. I know that last I looked, there were no firm guidelines, except your threshold's a little lower for going to look with imaging and trying to see if there was a kidney abnormality, but I don't know of any sort of steadfast guidelines on that. As you know, the standard is a CT scan with IV contrast. If you have the luxury of time, you'd want to wait 10 minutes, try to let that contrast get into the collecting system. As you know, it's notoriously difficult to diagnose ureteral injuries, so if you can let the contrast drift down into the ureters and get some good pictures there, that would be helpful. And then if there is no imaging and you're racing off to the OR and there's a concern for a kidney injury, before you take out someone's kidney for a trauma nephrectomy, I would recommend you give some IV contrast, 2 mg per kg, wait 10, 15, 20 minutes, shoot a plain film, and just make sure they have 2 kidneys. I actually know of a situation where that happened. They took out a kidney and then they realized he had a congenitally absent kidney on the other side, which is obviously unfortunate. There is a grading system for renal trauma, 1 through 5. 1 is a little contusion, 2 is less than 1 centimeter into the parenchyma, 3 is more than 1 centimeter, 4 gets more central into the collecting system and also some contained vascular injuries, and 5 is a completely avulsed hilum or shattered kidney. Things have changed, as you probably know, over the last 10 years. Most 1 through 4s can be managed conservatively. There are some 4s that are managed operatively or in IR. Grade 5s still need an intervention, most commonly relatively urgent, going to the OR. And this is basically what I had mentioned before, how we're trending more towards observation of traditional renal trauma. If there's extravasation in of itself doesn't really bother us unless it's ongoing, persistent, or if someone's having symptoms from it, if they're grossly distended, if they're having fevers. Oftentimes, extravasation of urine will resolve on its own as long as it drains well down the ureter as well, but there are times where putting up a ureteral stent can help facilitate that process. And obviously, if there's a lot of urine there, if it's symptomatic, but you're not going to the OR, you could put a drain in it as well as the ureteral stent. Embolization is a good trick to have that can save you and the patient a bunch of hassle. And so embolization rates for managing serious renal trauma are actually pretty good, and you can always repeat it if needed. If you have the luxury of a good interventionalist and you think it'll be amenable to it. Do not use it for a grade 5. There's nothing that they can do to prevent a grade 5 from stopping bleeding. So operative management, I alluded to it earlier. The absolute indications are listed. They're just basically ongoing bleeding. If you're already in there for another reason and you see an expanding or pulsatile hematoma, you need to do something about it. Grade 5s need to be operated on. And then grade 4s, if you're in there for another reason and you think you can do the patient some good, it would be worthwhile considering it, but that's not always the case. The relative indications that are listed there are relatively rare and relatively loose. I can't think of a single time where, and I don't do a ton of trauma, but I can't think of a single time where one of these were the only reason we ended up going to the OR. I guess if there was just ongoing leakage of urine from a ureter that you couldn't manage with a nephrostomy tube and a stent, which would be really rare, that you would have to go in and fix it. So technique, a good practical trick for early, quick, easy access to the left renal hilum is once you get in and scoop the small bowels out of the way, find the IMV on the posterior wall of the mesentery, go just medial to it, and you can feel for the renal artery and vein, and you can make a little incision there and pretty quickly get to the left renal vein and renal artery. On the right side, obviously, you just want to flip the colon, and you can get to the renal vessels that way. Ureteral trauma, notoriously difficult. Have an index of suspicion. If you're in the OR, obviously you can use any number of dyes that are available, and they're not always available. But give it some time to travel through the system, particularly if they've had bouts of hypotension or hypovolemia. And you can see if there's just gross spillage of that blue material and go track something down. Bladder trauma, usually with other injuries, almost always with some form of pelvic fracture, though there are other instances where it can happen. They will get imaged if there's gross hematuria. If there is a known pelvic fracture, you want to evaluate for bladder trauma. And then obviously if there's just a belly full of fluid and it's not because of blood, your first suspicion would be that there's urine coming from somewhere, potentially the bladder. How do you diagnose this? The take-home point from this is you got to fill up the bladder to a meaningful amount. The traditional is 350. I mean, it really doesn't matter if it's 300, 400. Just make sure you fill the bladder enough. What you don't want to do is say, oh, they're getting a CAT scan, let's just clamp the Foley and let the contrast run through and enough will get in there. Get enough in retrograde through a Foley, or if you're doing a traditional cystogram, you can do it that way, or obviously a CT cystogram as well. If you do a traditional cystogram, non-CT, you want a scout film, you want an AP and a lateral, and then you want a post-drainage film in order to make sure you're not missing any abnormalities. Treatment of bladder trauma. Intraperitoneal is thankfully more rare than extraperitoneal. And as most of you know, the extraperitoneal injuries almost always heal up with just Foley catheter drainage, unless something is in the way of it healing, like there's a piece of bone sticking through the bladder injury. The reason intraperitoneals get fixed are really twofold. Number one, if there's ongoing leakage of urine into the peritoneum, it causes all sorts of other problems. But the other one is that if you have a hole in the dome of the bladder and a little knuckle of small bowel gets in there, it's never going to heal up. So there are reports of conservative treatment for select intraperitoneal bladder injuries, and we've done that on occasion with success, but for the boards, an intraperitoneal injury is go fix the bladder. So indications for exploration, we talked about intraperitoneal injury. If you're in there already doing other things and there's a hole in the bladder, they're usually really easy to fix unless they're down by the trigone where the ureters are. Even if it's an extraperitoneal injury and you're already in the abdomen, go close it with some absorbable suture of your choice. If you can get 2 layers in, great. You obviously keep a Foley catheter or a suprapubic tube. Usually about a week or so is sufficient. We typically don't even check a cystogram. If it's just a traditional injury, you've had good drainage, pull the catheter after a week or 10 days. If there's any concern that it may not heal, you obviously can always get a cystogram before removing any tubes. I alluded to it earlier. If there's any other concomitant injury with risk of fistulization, rectum, vagina, you want to fix that in a timely fashion rather than just bathing both injuries in urine. And then an open fracture of the pelvis. Urethral trauma also typically follows a pelvic fracture. There's all these signs that are listed. Some of them, like a perineal hematoma or gross hematuria, you'll see. The high-riding prostate was, we were taught all the time, it's pretty rare that you do an exam, you're like, ooh, that's a trauma exam, and ooh, that's a high-riding prostate, let's go image everything. You usually have some other stuff going on as indicators. I still think for a board exam, if you've got blood at the meatus, the smart answer is a retrograde urethrogram. The reality of it is you can gently take a well-lubed catheter and slide it in. If it slides in, fine. You're not going to convert a partial tear of the urethra into a full tear of the urethra just by gently placing a Foley in there. Cystoscopy is also helpful. Many of you know how to use scopes. Our cystoscopes are no different than some of the upper GI scopes or choledocoscopes or other things that some people use. And if you're comfortable, go for it. So retrograde urethrogram is pretty simple. Find a catheter, put it just inside the tip of the penis, get a couple cc's in the balloon so things don't leak out around, and put your contrast through there. Again, take laterals so that you can get a good view of things. An AP for this isn't very helpful. And again, cystourethropy, which is basically some form of a telescope with direct vision, is helpful. There's ports where you can put wires through and eventually use a Seldinger technique to get a catheter through if you need to realign things. Fallback option is always nice with a suprapubic tube. If you can't get a Foley in and they need to be drained, suprapubic tube. In a very rare situation, if you need drainage and you need to go higher up, bilateral nephrostomies will proximally divert everything. Pretty rare that that's the case following a trauma. Primary realignment, we already talked about all the tricks up your sleeve. Blind catheters, okay, cystoscopy, or if you're in the OR, you can place something, or sometimes if someone has a suprapubic tube, you can put scopes through there, antegrade, and realign the urethra. Penile trauma, we talked about in the question. It's a breaking of the tunica albuginea. So it's usually during vigorous or creative sexual positions, and while the man's rigid, things crack, and it's basically an opening of all the blood and leads to a big ecchymotic bruise. Typically not painful, but often very embarrassing. They come into the hospital because they're seeing their penis blow up and get all bruised, and they're very worried. You usually go repair that in a timely fashion. It's not a true emergency, but you want to fix it because if you don't fix it in a timely fashion, they can have long-standing erectile dysfunction. And like I alluded to before, either in the OR or beforehand, try to do some type of urethral imaging so that you rule out a urethral injury. Testicular trauma, so low index of suspicion for an injury leads to an exploration. It is a really, really easy exploration, so have a low threshold. You make a scrotal incision, stare at the testicle, and see if there's an injury. Ultrasound, if you really want to test, you can get it. It's not great, though, and I would tell you, as we tell our residents, I mean, it's kind of like the case with appendixes. You have a few white appendixes, you're fine. Same with this. If you need to make a little incision, look at a testicle, drop it back in. Better to do that than to miss a real testicular trauma. All right, some areas of overlap that we have. The question is, during a low anterior resection, the left ureter is transected 1 centimeter proximal to the bladder using the GIA stapler. The most appropriate next step is A, percutaneous nephrostomy, B, indigo-carmine, C, a transureteroureterostomy, D, a ureteroureterostomy, or E, reimplantation of the ureter into the bladder. Well done. Means I need to change this question. So E is reimplanted. Basically, if there's an injury below the iliac vessels, one way or the other, you can almost always get it reconnected to the bladder, and I'll show you some other tricks to have up your sleeve, which many of you may know. Don't get lured into a distal injury trying to reattach it. Primarily, they tend not to heal very well. Next question. The quickest and easiest form of urinary diversion associated with the lowest risk of complications following a pelvic exoneration is A, a sigmoid pouch, B, an ileocecal pouch, C, an orthotopic neobladder, D, ileal conduit, and E, transverse colon conduit. And you all are rocking and rolling. Good, ileal conduit. And we'll get into some of those details as well. So herniorrhaphy, anytime you or us are in the inguinal canal, as you know, there's a risk of neuralgia afterwards. The nerves, ilioinguinal and iliohypogastric. I used to try preserving the ilioinguinal every time during orchiectomy until my general surgery colleague showed me the literature that doesn't really matter. Whether you divide it or whether you keep it, the rates of neuralgia, at least what they had showed me, were the same. So it makes sense to save it, but probably not absolutely necessary. Testicular atrophy is certainly something to worry about, but you should take comfort in knowing there's a dual blood supply to the testicle. So there's the main gonadal artery, which comes up from near the kidneys, because that's where the testicles started embryologically, and they course through the inguinal canal. But there's also a backup system of vessels that come off the hypogastric vessels that go down the vas deferens and the cremasteric vessels. So even if you knock off a gonadal artery, if that's it, the testicles should still live. The people that you got to worry about are people that have had a vasectomy before, and then you knock off a gonadal artery. Now they've got nothing, and the testicle will shrink up. Ureteral injuries, as you know, prevention is the best policy. Have a low threshold for asking your local friendly urologist to put a stent or catheter up before a case. You can leave strings on it and take it out, or they can go back to the clinic just for intraoperative visualization. You know about the dyes. I don't have to reiterate that. So the intraoperative repair really depends on a lot of nuances and details. Where is the ureter injured? How was it injured? How much was it injured? And the condition of the patient. So we'll go through a lot of these different possibilities, but you really have to incorporate all those things before making the final decision. So a ligation, laceration, or small resection, you can do primarily if it's above the vessels, if it's the iliac vessels. If it's below the iliac vessels, I would encourage you or your urologist to do a reimplant. So if you do an end-to-end anastomosis of a mid-ureter or upper ureter, you can mobilize the kidney a little. You can drop a kidney a solid 5 to 7 centimeters just by going laterally, superiorly, inferiorly, and just loosening it up and dropping it, and the renal hilum will become at a more of an angle. You want to spatulate both sides of the proximal ureter and distal ureter on the opposite sides, obviously freshen them up. You want to get a stent in there, and then we tend to use interrupted 5-0 absorbable sutures. And you leave a drain nearby. If the omentum's nearby, you can wrap it, but that's basically what you would want to do. We already talked about distal ureters doing ureteral reimplants. Sometimes it automatically connects up, but the tricks that you want to have up your sleeve are a psoas hitch, which I assume you all have heard of, and you are all capable of doing it. If you do a Boari flap, you probably want to get a urologist into the room. So a psoas hitch is basically mobilizing the heck out of the bladder, and I alluded earlier to the great blood supply. If you need to do a reimplant on the left side of the bladder, go on the right side of the bladder and divide anything you want, okay? The bladder will live no matter how many blood vessels you take on the right side. Then mobilize the bladder, take the dome of the bladder and basically pull it up by the psoas muscle. Be careful when you tack it up to the psoas muscle, when you put your suture there, you typically want to do it in a craniocaudal direction rather than a medial lateral, and the purpose of that is you don't want to entrap the genitofemoral nerve. So your suture wants to be parallel to the genitofemoral. And then once you tack it up there, you basically open up a part of the bladder and plug the ureter in there, spatulate it, and use some interrupted absorbable sutures. The Boari flap, it looks really easy, and it's not as easy as it looks. So you always want to do a psoas hitch before considering a Boari flap. So you can do the psoas hitch, and if you're still not getting your ureter to the bladder, probably time to consider a Boari flap and give your urologist a call. And it's basically taking an anterior part of the bladder, flipping it up, rolling a tube, and connecting things. So sort of middle or proximal injuries, some of these are challenging because you don't have a lot of proximal ureter to work with. But things you want to know about is our primary anastomosis, as long as it's not under tension. We already talked about that. You can swing a ureter to the other side if you have enough length. So you put it under the mesentery and basically connect it into the other ureter. That's pretty rarely done, but something to know about. There's bowel interpositions for panureteral strictures if the whole stricture is damaged. I can't think of a situation where you would face this, but we occasionally see it where someone's had long-standing strictures and there's just no ureter to work with. And your option is basically take a segment of ileum and just interpose it. Or you can do an auto transplant where you bring the kidney down to the pelvis and just take the renal collecting system and plug it directly into the bladder. Those are really the only options that are available. During a surgery, if there's a major proximal ureteral injury that you can't repair, and particularly if you have to get the patient off of the table, you can just tie off the ureter, put a nephrostomy tube, and let your urologist deal with it on another day. Alternatively, a nephrectomy is something that you can consider, though it should be relatively rare to do a nephrectomy just for a severe ureteral injury. Here's schematics of all these things that I talked about. They are self-evident as you look at the pictures. The TUU, the transureteroureterostomy, I don't know if they would ask you this, but the contraindications are if someone has a history of kidney stones, and the reason is if you drop a kidney stone down near the bladder, it's going to block both kidneys rather than just one. Or if someone has a history of upper tract urothelial cancer. So bladder cancers are common. Less common, but the same type of cancer are cancers of the ureter and the renal pelvis. And if they have a history of those upper tract cancers, at least we're taught not to do or consider TUUs. All right, recognizing a ureteral injury post-op, I'm not going to spend time doing this except you have to have it on your mind. So Usually just, fluid in the belly, fevers, or fluid coming out from some part of the body that it's not expected. And you can always send that fluid for creatinine level. So if it's just serum coming out of, let's say, the incision, and you send it to the laboratory, and the creatinine of that fluid matches the serum creatinine, it ain't urine. But if you send that fluid and the creatinine is 20 or 30 or 40, you got urine in that fluid somewhere. So it's a quick, easy thing to do to test for it. There's all sorts of ways of trying to diagnose it and deal with it. It's notoriously difficult, and then treatment really just depends on the specific of the case, and you know all the tricks up our sleeve or your sleeve to do it. Moving on to urinary retention. So post-op urinary retention is the bane of your existence and ours, more so, the consult for it. Always rule out a urinary tract infection. Try to have someone document how much urine was in the bladder when they put the catheter in. That will help dictate how long we need to keep the catheter. There's a big difference between someone that retained 300 cc's of urine and 3 liters of urine. You want to know their surgical history, their urologic history, if they have a history of urethral strictures or BPH. Easy to rule out an infection. We almost always empirically start an alpha blocker. We usually use tamsulosin. You've probably seen it. It's called Flomax, 0.4 milligrams, really safe drug. They start taking it every day. And then there's a voiding trial at some point, and it obviously depends on the condition of the patient and how much urine they had left in their bladder. You and us often meet in the operating room for these cases. Necrotizing fasciitis can come from the GYN organs, the GU organs, the GI organs. It's just wide local debridement. You've probably seen it where the blood supply to the testicles, as I alluded to earlier, come from the upper retroperitoneum. So I've never seen a case where the testicles are involved, and oftentimes you debride the heck out of everything, and then you literally have 2 spermatocords and testicles flopping in the breeze, and you either wrap them or stuff them in a thigh pocket, something to protect them before they get skin grafted down the road. Have a low suspicion. You know this disease perhaps even better than we do. So, enterovesical fistulas, as you know, usually diverticulitis, but you have to think of cancer. There are a bunch of different signs, recurrent urinary tract infections, particularly with mixed bacteria, fecal urea, bubbles in the urine that the patient reports, or sometimes just incidentally on imaging. Surprisingly challenging to definitively diagnose. CT scans are helpful. We sometimes put cystoscopes in. There's an older paper that shows the single best way is they basically take a bolus of sesame seeds, and then a couple days later they report to you whether they saw any sesame seeds in their urine. And by definition, if it's in their urine, they have a fistula. The treatment, you can try giving it rest. There's certain situations where there's a decent likelihood, and others where it's just really unlikely, and then ultimately repairing it. Many times you do the repair, you do your sigmoid resection or other area of the bowel, you take a little cuff of bladder and you can repair the bladder yourself. If it's near the ureter or the trigone, oftentimes we get involved. Pelvic exenerations, many indications for them. 3 different categories of urinary diversion. Simple, easiest, quickest is the incontinent one. It's basically a stoma or a urostomy. It's called an ileal conduit. Second is a continent catheterizable. So that's most commonly called the Indiana pouch, but there are literally dozens of other kinds of pouches. But basically you make a pouch that is a reservoir for the urine. The ureters go in one end, and the other end comes to the skin, and there's some form of continence mechanism that I won't bore you with. But they basically take a catheter a couple times a day and put it in the continence mechanism and drain their pouch. The third, and commonly done after bladder cancer surgery, is a neobladder, which is taking a really long segment of small intestine, detubularizing it, making it into a pouch, plugging in the ureters, and then taking the most dependent portion and hooking it up to the urethra. And most times the patients really like it in that they can remain continent. There's no external bags or catheters to put in. There obviously are a whole host of potential complications that come with it that I won't bore you with now. Here's schematics of it. Ileal conduit you've probably seen, perhaps even done with your partners, with your urologic partners. The continent catheterizable, the one I'm showing you there, is probably the most commonly done. It's called the Indiana pouch. And it's basically taking distal ileum, the ileocecal valve, and a little bit of proximal colon. The proximal colon gets detubularized and made into a pouch, and then the ileum gets brought to the skin, and the you taper that ileum, and then the tapered ileum and the ileocecal valve become the continence mechanism. The orthotopic neobladder, you see there's a limb on it where you get the ureters up away from this neobladder, and all the urine sort of comes down this limb into the pouch itself, and everything ultimately goes down through the urethra. I list this for completeness sake. I'm not going to get into the details. This is a whole 2-hour talk on its own on how to manage urolithiasis. Bottom line is there are genetic factors. The most common risk factor is dehydration to any degree. They're more commonly seen in bariatric surgery patients. They're more commonly seen in the southern United States where it gets warm. You know the symptoms of acute colic. It can happen most commonly in the kidney, but obviously, depending on the location of the stone, it can happen in the lower quadrant, or it can happen in the referred pain down to the testicle, or in women down to the labia. So a distal ureteral stone can lead to distal symptoms down by the testicle or labia. Non-contrast scans are the way you diagnose it. 95% of stones are radio-opaque and will show up on a non-contrast scan. If someone has recurrent stones, you want to do some form of evaluation to prevent it, either lifestyle or medications. Probably the most important thing for you if you work at a place without a urologist is a stone obstructing a ureter with signs of infection is an emergency. It's basically an abscess in the upper urinary tract with nowhere to go. And people can get pretty sick pretty quickly, and people can die from bacteremia and sepsis unless it's drained. Ways to drain it are either with a stent, that's preferable and easiest and nothing external, but if you don't have a urologist, but you can have someone put a nephrostomy in, that's pretty quick as well, and you just get all the urine and pus out that way. How do you treat stones? It depends on a lot of things. There's your laundry list of mechanisms down there. There's conservative management, where you basically push fluids and give someone an alpha blocker. There are alpha receptors in the distal ureter that relax the ureter, and randomized trials have showed that helps the passage rate of stones. And then there's all different ways we can break them up, externally, internally. And for really big stones, we put tubes into the kidney and go in with big scopes and take them out. Here's an example of someone with, unrelenting right flank pain. This is probably a centimeter stone, and you can do it with the external beams. That's the ESWAL, extracorporeal shockwave lithotripsy, or these cool little ureteroscopes where you can put lasers and baskets, and you go in through the urethra, up the ureter, and you can deal with stones like this. This is a bulkier stone. This is a staghorn calculus, and these are dealt with nephrostomy tubes, and you do a percutaneous nephrolithotomy. You use your same instruments, but they're bigger, and you just go straight in through the flank. Old school, this would be an anatrophic nephrolithotomy. It would be an open surgery. You open the kidney and basically scoop the stone out. Here's a tiny little left distal ureteral stone. If this was causing, constant symptoms and needing an intervention, you'd go put a little ureteroscope up and either just basket it or laser it into fragments, and it would pass. Testicular torsion, typically kids, but you can sometimes see it in adults. The classic example is someone saying, I was sitting there, everything was going great, and instantly I had the most severe pain in my life, and I just got up out of my seat and couldn't stand still. It's just severe, severe pain, and it's the twisting of the cord, and it's basically acute, loss of blood flow to the testicle. So you want to have a low suspicion for this for obvious reasons. You can try untwisting them. It's rarely successful. And again, similar to your testicular trauma, you have a low suspicion of just making an incision, looking at it. The testicle will either be white or blue. You can use ultrasounds, for Dopplers to reinstitute blood flow and see if it's living. If you can save it, you want to tack it down to the dependent part of the scrotum. And the classic teaching is you do it on the other side as well, even though they haven't had symptoms on the other side. That's a little debatable, but for test purposes, I would say while you're in there, you just tack down the other side. All right, 3 final topics, all cancer related. I'm going to whip through these so that we have plenty of time for questions, and since I know that you're a little behind already. Question: which of the following is a risk factor for developing testicular cancer? A, steroids. B, cryptorchidism. C, trauma. D, marijuana. E, being African American. Great. You all are rocking and rolling. I'm curious if it's the same 89% of people getting each question correct, but So it's the most common solid cancer from about age 15 to 40. It is the ultimate model of success. So 95% cure rate by integrating chemotherapy and surgery, and there's all sorts of different paradigms depending on what type of testicular cancer it is. There are right and wrong answers. Unlikely you need to know any of those pathways. Risk factors being Caucasian or Northern European, it's basically really uncommon in African American folks or in Africa itself. It's less common in Hispanics, though interestingly rates amongst Hispanics are the most rapidly rising. Very rare to have a familial or genetic component to it. The most common risk factor is cryptorchidism, but amongst all people with testicular cancer, about 5 to 10% of them have a history of cryptorchidism. Most commonly is a palpable mass, though there are other ways that men will present. Ultrasounds are the test of choice to look for a hypoechoic mass of the testicle. There are blood tests that we have that are really useful and help dictate treatment. Those are AFP and HCG. Those are not always elevated, but when they are in the setting of a testicular mass, you have your answer. All treatment decisions with testicular cancer are based on 3 things and 3 things only: the histology of the cancer, the blood tests, and a staging evaluation with CAT scans. The staging situation is basically stage 1 is limited to the testicle, stage 2 is the retroperitoneum, and stage 3 is above the diaphragm. 2 main categories. Seminoma is a pure component, same histology throughout. A completely different category, completely different management paradigm is non-seminoma, which is sometimes referred to as mixed germ cell tumors because there's many different components that make it up. The testicular cancer almost always metastasizes to the upper retroperitoneum because that's where the testicles started. There's no such thing as a sentinel node, but there are common patterns, and for the most part, left-sided stay left-sided. Right-sideds go right-sided, but they can cross over from right side to left side. The opposite is not true, and I don't know if that's testable for you, but we do often see right primaries going to the right retroperitoneum, crossing then over to the left. The opposite is not true. I put this for your reference. I'd be shocked if you got asked about these, but there are many different options depending on the stage and histologic type. I highlight the thing at the bottom. I see all the testis cancer patients at our institution, and I would tell you once a year, maybe twice a year, I see a kid who comes in, they had a retroperitoneal mass. They showed up with some symptom, someone scanned them, there's a retroperitoneal mass. I would urge you and beg you, anyone between the ages of 13 and 50, if they come in with a retroperitoneal mass of unknown origin, feel their testicles, get an ultrasound, get those blood test markers, and you may save the person either an XLAP or a biopsy or just any other diagnostic evaluation. Kidney cancer. Question is, a 50-year-old male with stage 4 chronic kidney disease is diagnosed with a 4-centimeter exophytic solid enhancing left lower pole renal mass found on CAT scan. No METs. Next step is A, MRI, B, biopsy, C, radical nephrectomy, D, radical nephrectomy with lymph node dissection, and E is partial nephrectomy. Good. So most of you chose partial nephrectomy. So we have a lot of options available for people with small renal masses. Small renal masses, by definition, are 4 centimeters or less. Many of them, particularly the smaller ones, we observe. Sometimes we biopsy them. Sometimes we ablate them. Sometimes we do partial nephrectomies. Sometimes we do radical nephrectomies. In someone that has stage 4 chronic kidney disease, if it's amenable to a partial nephrectomy, you'd want to do a partial nephrectomy. Let them keep all their normal nephrons. For the most part, a good partial nephrectomy versus a radical nephrectomy, same long-term cancer control. Partial nephrectomy, for obvious reasons, has more potential complications afterwards, bleeding from the bed of the kidney or leakage of urine from the bed of the kidney. Epidemiology of it, not all that interesting for you, except to say there's been a downward stage migration. So this has happened over the last 25 years, where more CAT scans have been done and finding more little ditzels in the kidney. If you see a simple renal cyst on some scan you get, you can ignore it. If there's any complexity to it or if there's a solid mass, have them see a urologist. You can reassure them most really small renal masses we follow. I can't remember. I remember operating on a 1 or 2 centimeter renal mass in recent times, and oftentimes they've been that way for years and they continue, and we don't need to do anything about it. Here are the treatment options that I already alluded to. The rationale for partial nephrectomy, if you're interested in reading about it, you can. I'm not going to go over it now, just so we have time at the end for all questions. I alluded to this, that many small renal masses we observe, not all of them are cancer. The average annual growth rate is 2 to 3 millimeters. The rate of metastasis, even if it's cancer, really don't start getting above 1 or 2% until the mass gets above 3 or 4 centimeters in size. And so many of these get followed, particularly in older, sicker people. Metastatic kidney cancer can go anywhere in the body, but the most common places are lung, bone, liver, and lymph nodes. It is somewhat rare. Perhaps the corollary in your field is colorectal cancer, but there are situations, people that have kidney cancer with a solitary metastasis where they can be cured for a long period of time, and some forever, with a metastasectomy of a solitary metastasis. And so there are situations that we do that. But widespread metastasis is systemic therapy. No chemotherapy agent has ever been shown to work. They're all immunotherapy agents, or more commonly now are targeted therapy agents. They basically don't cure anybody, but they do extend life on average, 3 to 12 months. This is perhaps testable on a surgical board exam. Is that there is some data, it's older data, but there were 2 large randomized trials taking people with metastatic kidney cancer and randomized to best systemic therapy or a cytoreductive radical nephrectomy followed by systemic therapy. They were positive studies. They extended life on average by 3 to 6 months. Not everyone with metastatic kidney cancer gets a nephrectomy. There are some nuances in there. For the most part, if they have lung-only metastasis and they have a decent performance status, you'd consider doing a nephrectomy because the survival advantage is greater than 6 months. In particular, if you can do a laparoscopic nephrectomy where they're in the hospital overnight, go home, and you can give them a survival advantage from that. The last main topic is prostate cancer, and then hopefully we'll have about a maximum of 10 minutes for questions if you wish. What is the most common presentation prior to a prostate cancer diagnosis? A, nocturia, B, urinary retention, C, elevated PSA, D, prostate nodule, and E, bone pain. I'm looking for 100% success on this one. So most commonly is an elevated PSA. So we could spend a week-long conference talking about prostate cancer. I will keep it really short, and if you have relevant questions, I'm happy to go over it. Highly controversial. We used to never screen, then we screened everybody. Now we're somewhere in between, and we're smarter and better at it. PSA screening absolutely positively saves lives. 50% fewer men dying of prostate cancer in the United States since the introduction of PSA. There's a lot of baggage that can come with it. So there's an epidemic of overdiagnosis, overtreatment, basically finding cancers that the patient never needed to know about. I guess the corollary in your world would be DCIS or some whatever that rare thyroid cancer is that recently was reclassified. So we have tests now that are better than PSA. They outperform PSA. Their blood tests or urine tests are unfortunately all very expensive, and there's no way they're testing you on that. The downside of the PSA is there's a lot of things that can cause your PSA to be high. In general, as you can see from the figure here, there's no such thing as a quote-unquote normal PSA, but as your PSA gets higher, your risk of having any prostate cancer or a high-grade prostate cancer goes up accordingly. Risk factors for having a meaningful prostate cancer, there's really 2 main risk factors, and that's being of African descent or having a strong family history. If dad was diagnosed with prostate cancer at age 75 and had a wimpy little cancer, that is not a family history of prostate cancer. But if your brother and your uncle were diagnosed at a young age or anyone died of prostate cancer, that's a legit concern. People who advocate for screening would say somewhere between age 45 and 50, get your baseline PSA and then manage things accordingly. We still do advocate for a digital rectal exam. There are some prostate cancers that don't produce a lot of PSA, but you can feel them on exam. We talked about high-risk populations. This is a graphical way of looking at incidence and mortality. The people who are virulent against prostate cancer screening, and there are many, can make an argument that because we're overdiagnosing and overtreating people and there's risks to treatment, that we should just first do no harm, and we will basically allow some people to die of metastatic prostate cancer, but then we'll at least save people the unnecessary screening biopsies and interventions if they didn't need it. If you're a man in this room and you take your age, put a percentage after it, that's your risk of having prostate cancer right now. So autopsy studies will show that if you take 30-year-olds that die of trauma and you look at their prostate, 30% of them have histologic prostate cancer. Now, very few of those will have clinical prostate cancer down the road, and that's what we're trying to get better at. The histologic scoring system that you may have heard of is called the Gleason score. It's a really goofy system. It goes from 6 to 10. 10 is the highest, most aggressive. 6 is the least aggressive. I would argue that a Gleason 6, which we notoriously treated aggressively every time, Gleason 6 is basically like a basal cell carcinoma. It can't metastasize, it can't cause problems, and those are exactly the patients nowadays that we almost always put on surveillance. We do not do surgery or radiation, but we just keep a close eye on things. But a young, healthy man with a Gleason 7, 8, 9, or 10 cancer certainly would benefit from considering treatment. This is a suggestion from a previous year. They said, can I have just a one-stop shop for prostate-related medications with their names, their mechanism, what they do, and so I'm not going to go over it, but it's there for you if you want to have them. That's what I got. So hopefully you found it useful. Just to emphasize again, please send feedback. I look at it and pay attention to it, both good and bad. So thanks for your time. Hopefully it was helpful.
So that stage 4 kidney failure patient with a 4-sign lesion, why wouldn't you biopsy them as opposed to just doing partial nephrectomy?
It's a great point. And I can't, was that one of the options that I gave as a possibility?
Well, the answer to the question was that you would do a partial nephrectomy.
Yeah. You're absolutely right, is the short answer. And that would be so historically, I'll give you a 1 minute on this. Historically, we never, ever, ever did renal mass biopsies because there was this threat of it bleeding or spreading the cancer. And that was passed down from the urologic gods even when I was training. That has been, both of those have been completely debunked. So there are situations now, more and more, where we biopsy small renal masses to find out what they are, and you can save people interventions. Some of them are benign, some of them are really wimpy kidney cancers with a low risk of metastasis.
So what's the board answer?
I would say either. I can't imagine they would say partial nephrectomy and biopsy on the same list. Okay. I could make a solid argument for both of them. You definitely don't want to do a radical nephrectomy. You don't want to do ablation on anything that's more than 3 centimeters or so because the success rate isn't good. So those are definite wrong answers, but you got many good answers.